This year is the first year that we've invited nursing personnel, physicians, and we've also included boards to have some networking done. And I'm really, really pleased to see our board members from the DSAB and the hospital board from the North Bay Regional Health Center being very active in the community. So our goal is to be doing more networking, see what the needs are, and deal for the patient. That's what we're here for. Focus on the patient, not on what we think we need for the patient. Anyway, my pleasure today and honor to introduce to you is Dr. Brian Goldman. Dr. Goldman. Heard Dr. Goldman on the radio a lot because I listened to him. And it was great, you know, to call the bureau and say, is Dr. Goldman available for October? Let's see. So they call him and say, would you like to go to North Bay? Of course. And more than that, he was generous with his time. So thank you very much, Brian. Appreciate it. Brian is a veteran emergency physician, works at the Mount Sinai in Toronto. And he's also a renowned medical broadcaster. He has been an award-winning medical reporter for CBC Television, The Health Show, as well as National. He's known across the country as CBC Radio 1's house doctor. On White Coat Blackguard, he takes the listeners past medical bluff and bluster and shows what really goes on at hospitals and clinics. Brian is also author of Night Shift, Real Life in the ER, which takes the readers to the front line of emergency medicine and offers compelling inside view into the often shuttered world. And you all have a copy of this book, so enjoy it. Brian, the floor is yours.
Thank you very much. I am very honored to be here, and I want to say, first of all, that I forgive you for wearing an orange shirt. If I'd only known, I would have brought my orange shirt as well, because my beloved partner Tamara loves the way I look in it. So thank you very much for coming here. And I also want to say I love paramedics. I had to do a radio show, and I had to meet them close up to stop being the guy who growls at them as they bring patient after patient into the emergency department, and realize that we're all, I think isn't that the problem in healthcare? I'm so glad that there's allied health professionals here, because don't we all have this empathy issue, you know, where we have difficulty just seeing what it's like to be on the other side? You know, whether it's us, it's hard to know what it's like to be a patient or a family member, or to be an emergency physician, to know what it's like to be a paramedic going out there into the unknown all the time, for a nurse to know what it's like to be a physician, for a physician to know what it's like to be a nurse. And one of the nice things about bringing allied health professionals together into one room is that you get to learn a little bit about each other. And I'm going to share that. I'm going to talk about some of the problems and some of the solutions. I'm going to focus on you know, some attitudes towards seniors, and just talk about not just that, but the system problems that I think we need to fix. And then I'm going to talk about some of the fixes, you know, a little bit about making primary care more efficient. And you know, one of the big things I really want to talk about is how we can get everybody who works in healthcare to practice up to the top of their scope of practice, instead of trolling around the bottom of the scope of practice trying to supplement our incomes and to just get through the day. And ultimately, though, we have a healthcare system which, as you know, it's a patchwork. It's very fragmented, it's very scattered. In some places it's coordinated, in other places it isn't. Some parts of the country they're doing some things well, but you know, move a few counties down or a couple of provinces down and you find that they don't even know what they're talking about. So you know, I think, you know, if I could wave my magic wand, I'll talk about one of the things I would do to fix the healthcare system, although to change the entrenched system as it is right now would take a long, long time. I was told, at one point this was laughter and tears, so I guess I got to make you laugh. I wouldn't be here today if I didn't sleep in one morning. If you read my book, if you get through that part of the book, I talk a lot about insomnia. In fact, I'm a professor of insomnia. I have had this problem for about 30 years now called early morning awakening, where I can get to sleep, but I wake up 6 o'clock, 5, 4:30, and can't get back to sleep. My mind's just spinning and spinning and spinning. But one morning, except for one morning, and that was when I was supposed to deliver grand rounds in the Department of Neurology at Johns Hopkins Hospital in Baltimore. And that was the morning that I was going to impress my mentors, and I was going to score that letter, get that residency, and come back to Toronto as a neurologist. And so if you don't believe in guardian angels, that's my story. Somebody up there or someplace said, not for you, Goldman. It's not your destiny. So I came back to Toronto in the early 1980s. And I really didn't know what I was going to do with the rest of my life. And I knew, because I had done some writing in college, that I did like to write. I was the nerd who liked to write essays. I also liked to write comedy. And University of Toronto med school had a Daffodil, which was our comedy review. I remember writing a song called "The Girl with Treponema." That's a good medical joke. Come on. Ah, that's very funny. Tall and tan and young and lovely, etc. Okay, I won't sing it for you. But I had put that destiny aside. I didn't see it as a destiny. It was just something I put aside. And then I think that morning that I slept in, it was like, wait, you've got this other stuff you like to do. So I came back to Toronto and did a year of pediatrics, because I was signed up to be a pediatrician, to be a pediatric neurologist. And all those dreams kind of faded away. And then I decided to complement that year with a year of internal medicine. And then around about March of that second year of residency, I had some friends who were moonlighting in the emergency department. Now, you could do that in those days. Can't do that today. So my heart goes out to people who don't know young people who don't know what they want to do, and are afraid of making a choice now, lest they want to change their minds in 2 years and they can't undo what they've done. So anyway, I did this year of pediatrics, year of internal medicine, and then started to moonlight in the emergency department, first at Northwestern General, York Central Hospital, some community hospitals in and around Toronto. And I discovered I liked it. I liked it because it was intense, it was stimulating. Do you like to conquer? Who here likes to conquer your fears? Oh yeah, that's right. And you know what? We all of us who work on the front lines, I mean, certainly in the emergency department, you never know what you're going to get, life's like a box of chocolates. You never know what you're going to get. And I conquered my fear of so many different things. I just wanted to be able to throw myself into it, and I did. And you can make a difference in short order. I just 6 months ago, I saw a 19-year-old in the emergency department who came in at about 3:20 in the morning of a very, very busy Saturday night, now Sunday morning, and I was just way behind, and I had to get out of there at 9 o'clock. So I would hand over at 9. My successor would come in for the day shift at 7. And I remember that at 3:20, there was no way I was going to see this guy. He was one of about half a dozen people who were intoxicated who were brought in by EMS. And so he was put in a hallway, and you know what happens. And if you're from my side of the gurney, most of the time you just wait for them to wake up. Hey, I feel better, and they leave. And sometimes that happens without you even seeing them, or just having waving hi and bye. So at 5:20 in the morning, so 2 hours later, I'm still hopelessly behind, but I'm starting to get a guilty conscience because I have to do a book reading for the night shift at 10 a.m. and I hate that. I don't like to have to be someplace that soon after my shift. And you have 2 hours to clean up, and to finish your patients, send them home, refer them, whatever. 2 hours can be eaten up very quickly. At 10 minutes per patient, and you got 12 patients like that to do the math. It doesn't take long for 2 hours to be used up. But at 5:20, I went to see this guy. And because I had a guilty conscience, I can't leave it to Don Milady at 7 a.m. to just see this guy who's been waiting for 3.5 hours. And so I went to see him, and the chart says HBD, has been drinking. And the little triage note says HBD, was assaulted by a bouncer, found outside bar, facial injuries, right? And that's all. And the other thing I noticed as I approach him, he's in a hallway stretcher. So he's in plain view of everybody else, is that his name is John Doe 245. Have you ever, you know how we all try to rouse somebody who's got a decreased level of awareness? You know, those of you who aren't doing that these days, you remember what you would do. You go up to them and first thing you do is you call them by name, right? What do you call somebody named John Doe? So you kind of have to skip over that, like, hey, Mr. Doe, John. What if his name is Vlad, you know? I don't know. So you go up there and you immediately start to, you shake him a little bit, and, he kind of went like that, and then, so I started to do, my alarm clock, my little knuckle alarm clock. A little sternal rub, and he wakes up like that, and then, oh, this is good, but I want you to wake up and talk. So I go some more, and then finally he reaches out and punches me with his right arm. And, in the dim recesses of my mind at that point, there was something about this picture that wasn't quite adding up. And I'd had no progress notes. As you know, in the emergency department, unfortunately, patients don't come in with an LED screen that says, I have ACS and I'm about to go into cardiogenic shock in 32 minutes. I just went to his feet and pinched his toenail, and again, he kind of raised that leg up. You're not doing anything with the left side. And so I repeated this exercise once more, and then I got Vince Chang, one of the experienced nurses who I love. I'd go to war with this guy, and I said, do me a favor, hold his right arm down. I just want to see if he does anything with his left arm. And sure enough, he didn't. And the two of us had that holy moment. And this guy, every July 1st, when the new residents come to St. Michael's Hospital, the senior doctor says, one of you will miss a subdural hematoma this year. And actually, the fact is, if you've practiced in Emerge, who cares? Because they all have cerebral atrophy, and they can tolerate like a liter of subdural in their brains without coning. No, this guy had an extradural hematoma. You remember what happened to Natasha Richardson on the ski slopes? If somebody had put a burr hole in like an hour before, instead of trying to schlep her to another emergency department, she might be alive today. And one of the things that's great, I know you guys have trouble transferring. We have, when it comes to neurosurge, we have exactly the same problem you do. We may be 3 blocks from Toronto Western, but we may as well be in another continent. We're just another referring hospital. And they just, and they swear at us, and if the patient's over 85, they just start laughing as you start to make the referral on the phone. I know, I've been exactly where you are. There's only one diagnosis in the universe that will get a neurosurgeon to jump, and I mean jump, and that's an extradural hematoma, because it's binary. Have you seen any? Have you had that? I've seen 3. It's binary. Door number 1, dead, coning. Door number 2, complete recovery. Which is it going to be? So the neurosurgeon said, get him here. And I remembered Mark Bernstein, who's always yelling and always surling, saying, I'll get him a bed. Scratch that. Just bring him to my Emerge. He'll do better with a burr hole in my Emerge than he will without in yours. And we whipped this guy down there, and about 45 minutes later, he's on the table, and he has the clot evacuated, and the next morning, he's 100% intact. I can tell you that, listen, I have a TED Talk where I talk about all my mistakes, so I'm entitled to talk about all of those. The important message I'm trying to make here is that there's a lot of alchemy in this, right? I'm in awe of the fact that that man could have died waiting for me to do a neurological exam. So congratulate yourselves for being on the front lines and taking the risk that we all do. Somewhere around 2005, I got tired of just being on the air and not knowing what I wanted to say, just doing the news of the day. And I began to take notice of the amazing things that you and I say to each other when we think patients aren't listening. And then we clam up as soon as patients arrive. And I thought, what if I could bring those conversations to the public? What would they think? And that's what White Coat Black Art became. And what I'm going to do is I'm going to play you some clips, but along the way, and you're going to get to hear the words of some of the people. If you haven't listened to the show, and I know you're all busy, then you'll get a chance to hear the thoughts of us on a whole bunch of things that have to do with making healthcare better, our frustrations and our hopes and our dreams. In their own words, so don't blame me, I'm just the messenger. I was told that I needed to bring a little humor into this, so I promised that I will. All right, and for those of you who have never listened to the show, here's an excerpt. So the question I ask you is, what kind of jokes does a proctologist tell? And to answer that question, I bring you Dr. Marcus Bernstein, who is a colorectal surgeon at St. Michael's Hospital in Toronto. Have a listen. All right, that's all the laughter for now. We got some serious stuff to talk about. Okay, we know that we're in the midst of a second dip of a global recession. We've got budget deficits, and somewhere somebody's going to do something about the deficit. And if that happens, then I think there's going to be some pain, and some of it's going to be felt by us. And of course, these two individuals have been at loggerheads, and you know, maybe the names are going to change, but some of those issues are going to continue. The other thing I want to mention about this, we were having a very interesting discussion here, and I should say a few words about prevention, and I will do that later on, but prevention of what? You know, what are we dealing with? It's not just an aging population, you know, the fact that by the year 2050, 1/4 of our population will be age 65 and up, but more than that, the chronic disease burden, or the burden of chronic disease. And by that I mean everything from diabetes to heart disease, stroke, cognitive issues. Mental health issues are a big part of the chronic disease burden, and I know that's a big issue here. Osteoarthritis and many other diseases, cancer, of course. A lot of people don't think of cancer as a chronic disease, but it is. You know, if you've got it for 10 or 12 or 13 years, that's a chronic disease. And you know, the numbers, the cost of the burden of chronic disease is staggering. I don't know what it is for Canada, but I can tell you that for the United States, the most recent estimate by the Institute of Medicine, 70% of the $2 trillion that they spend every year on healthcare is to manage chronic disease. So it would really be nice if we could slice off a piece of that and use it to pay for prevention programs that actually address the real determinants of health. So we've already talked about the silver tsunami. They used to call it, silver, they'll call it the boomer tsunami, and then the post-boomer tsunami. But I guess the good side is that after the peak, we're going to have a decline in the number of percentage of seniors in our population, and when that happens, you know, we'll have other problems that we're going to have to deal with. A new normal that I've talked about right across Canada, and particularly in places like Northern Ontario, is the fact that many Canadians can't find a family doctor. Don't worry, I am going to talk about nurse practitioners later on. Don't worry about that at all. You know, in places like Sudbury, you know, I've heard Sudbury referred to facetiously as the orphan patient capital of Canada. You know, other places may vie for that. Burns Lake, I suppose, in northern British Columbia might. And you know, what we have there is an interesting scenario. We've got young patients. You know, we've got certainly a group of patients who find it difficult to find a family doctor, and you know, some of them are quite predictable. You know, people who are high demand patients, people who are going to require a lot of a physician's time, people who, for instance, are elderly, people who have cognitive issues, mental health issues, multiple chronic diseases, people who are going to have a lot of forms that have to be filled out on their behalf. And sometimes it's young people. You know, I spoke to one woman, Christina Clark, in Sudbury, who called up 125 physicians when she had a positive pregnancy test at a walk-in clinic and couldn't find a single family physician who could look after her. Eventually, she was looked after by the first Sudbury nurse practitioner-led clinic. So we've got that problem, and it's here and it's everywhere. And at the same time, wow, meanwhile, at the other end of the spectrum of physicians, we actually have the beginnings of unemployment. Did you know that? According to a survey by the Canadian Association of Interns and Residents, not published, but it was released to my show, and we had this show on unemployed physicians a few weeks ago. 1 in 4 residents are not confident about their job prospects. 4 in 10 aren't satisfied with the career counseling advice that they've received. This was the ad page in the Globe and Mail that we had, and it was the title of a presentation by a woman named Maral Uzunian, who has spent 18 years post-high school doing her undergrad, medical school, residency in cardiac surgery, PhD, fellowship. She's now in Texas doing a fellowship, and she's got a job. But she's in the bare majority. About 35% of cardiac surgery residents don't get a job. And that means one of three things. Either they continue to do fellowships where they, they're paid, they're not operating for food. That's facetious. That was meant to get people's attention. But at the same time, they're not practicing as they intended. And they've put a lot of years into that practice. And there are many specialties that fit that. I just want you to hear one of them right now. Walid Hammam, who just finished his orthopedic residency this past June. He's doing 2 fellowships, one at Sunnybrook and another one he's going to do at University of Western Ontario. I guess it's Western University now. He's doing that in part to learn new skills, but also to bide his time to increase his chance of finding a job. Have a listen. And think of the waste, because he didn't just train for free. We put a lot of public money into training him. So that's kind of ridiculous as well. How do we get there? How do we get to places like that? Well, our thinking is very simplistic. When it came to physicians, I like to say we threw the main switch. In the late 1980s, as we had budget deficits at that time, big recession at that time, some West Coast, British Columbia health economists said, hey, physicians cost a lot of money. And it's not just the salaries, but it's also, or the fee for service, but the costs that they generate in medications and in tests and in referrals. And so if we cut down on the number of medical school enrollments, then we can cut down the cost. And that happened. And medical school enrollment was cut down from about 2,500 down to about 1,500. And then we had a doctor shortage. And then they flipped the main switch back on. So more medical school enrollment. But for everything else, there is no planning. There is no correlation between the number of residents that we have that are training to be an orthopedic surgeon or a nephrologist or a neurologist or a neurosurgeon and the actual need. In fact, it's more correlated with how many residents the teaching program needs to run the program, to keep looking after patients so that the staff doesn't have to be doing care. And I think we have to rethink that one very, very carefully. But to do that, you have to have planning. Other factors that are certainly important: urban migration. In general, at least until NOSM, and I don't know if NOSM's going to make a huge difference in that. I hope it will. I think we're going to need some long-term data to know if that's the case. There's been a steady migration from rural centers, underserviced areas to urban. The phasing out of the rotating internship, a great idea. It needed to be done, but it wasn't done with planning in mind. And so there was no bridge. And as a result, we lost a lot of primary care physicians there. Another factor that's going on and that's contributing to the unemployment situation is that 2008 recession. And some of those surgeons who might have retired at age 62 or 63 found that their net worth had dropped so much that they said, no, I'll keep working. And besides, in addition to that, governments like Ontario threw a lot of money into wait times, and that meant there was more work, more operating room time, and they felt might as well work. I don't want to talk too much about physicians to make it seem as if that's the whole problem here. Certainly, this problem here, the money game in family medicine, has to do with the way we compensate physicians. And up until very recently, it was well over 50% of the compensation that physicians receive comes from fee-for-service. It leads to a certain style of practicing where a physician might decide they want to see 4 patients, 5 patients, 6 patients an hour. And if you start to do the arithmetic, that's 10 minutes per patient. And if you look at what they have to do to keep the lights on, the practice management experts tell me it's seeing 57 to 67 patients per week just to run their overhead. And so you begin to see the kind of churn that has to happen. Now you begin to understand why those high maintenance patients who might take 20 or 30 minutes aren't so desirable to a physician just starting out in practice. Because if you think about it, for every patient, you want every patient to take 12 minutes or 10 minutes. And yeah, everybody understands in the waiting room that you're going to be running a little bit behind, but not 2 hours or 3 hours behind. And that happens every night, for some people who still book them as if they can see 5 patients, but every one of those or most of those patients are starting to take 20 minutes. But for every patient who takes 20 minutes, you better find somebody else who's going to take a lot less. And now you see why they want more and more patients who are easier to see. It's not the physician's fault. If you have a system, people will operate the system it's human nature to their own advantage, and I could say we should put every physician on salary, but be careful, because if you put everybody on salary, then they may say, this is how much work I'm willing to do for this salary, and they will work to that point and not a moment longer. So there's gaming in every kind of system. So you've got to, if you're going to be thinking about doing that, I think you've got to do things like putting in incentives for productivity or incentives for outcomes, and that opens up a whole can of worms, and I think we should do that. But my point is that if you think that I'm dumping on physicians because of fee-for-service, I'm not. It's the system. They have to work in the system. And I think that overall, there's been way too much emphasis on controlling the overall cost and not enough on figuring out what's the value of everything that we do. And that's a big thing that we need to do that we haven't been doing. You know, I find that the pace of figuring out, you know, what would the correct fee be to look after a senior who has dementia, you know, in a family practice. I don't think we've done enough of that. And you know what, if you're on that treadmill and you burn out, I'm not surprised. You know, it is a recipe for burnout. But one result is that, you know, I say seniors, but think seniors, people with mental health issues, people with multiple medical problems are the ones that are being left behind. And I want you to hear a young family physician, Omar Chaudhry from Strathroy, Ontario, talk about that.
You've chosen family medicine.
And you know what? Maybe part of that is lack of exposure, maybe lack of mentorship. They went on to talk about how they all had mentors who loved working with older people. They had good relationships with their grandparents, and they were influential in their lives. But in a system that doesn't provide a lot of time, you know, I allowed you to peer into the family physician's clinic and to get a sense of that sense of rush. I have it in the emergency department as well, where we use verbs like slammed and inundated to talk about, you know, the bus pulled up, to talk about that. And you know, that when you know that there's 17 patients to see, and you know, if you're efficient, you might be able to see 4 to 5 of them an hour. That's 3 hours plus, never mind the people who come in after the 17. And you know, your first patient is 92, and they can't tell you what's wrong with them, and you know you're going to have to spend a lot of time. Yeah, you do feel that sense of dismay. But you know, it's a system in which patients are seen as the enemy, and there's something wrong with that. And I'm not blaming health professionals. This is partly the system that they work in. You know, ALC is a big issue up here. There's not enough long-term beds and not enough hospital beds as a result, and certainly the window that I see in the emergency department are patients backed up on stretchers because there's no beds available upstairs. You know, we have crisis planning, ways of dealing with it, but still, it's a problem all the time. You know, I remember when we had no beds in the waiting room, and now we have more or less permanently 5, 6, about 12. But none of that compares to this. This is, they call it corridor medicine in Quebec. You know, at Jewish General Hospital, where I did a story about corridor medicine, they can have as many as 40 stretchers in the hallways. 40 stretchers in the hallways, particularly when there's a flu outbreak. And at Jewish General Hospital, what they're scared of is the patient. They're not worried about patients who are admitted, because if they're admitted, it's like not my problem anymore. It's general internal medicine, it's orthopedics, whatever. They're worried about the patients who are brought in from the waiting room to one of those stretchers in the hallway, right? Who is a CTAS 3. And that person, you know, that person will go from having appendicitis to having, you know, to having a burst appendix, or probably more realistically, more seriously, a patient with, you know, atrial fibrillation and a bit of belly pain will turn out to have an ischemic bowel, and by the time they get to them and see them, they'll have several feet of dead bowel, and that's the thing that they're really worried about. And you know, certainly, I don't know if you've got this problem here, but certainly across Canada, paramedics, this is the first time I've breathed the word paramedics since the very, very beginning. They have a problem called offload delay. And offload delay, you know, we threw a lot of money at offload delay in downtown Toronto, and it helped. But when the tap gets turned off, we're going to be right back to this. And you know, we can talk. Nathan Stahl already talked about ageism. It's especially true in hospitals that there's just so much rush going on that you know, people sigh and mutter under their breath when somebody's going to take a lot of extra time. But, you know, I think in fairness, today, a nurse working on a ward in the hospital is probably seeing more patients. There's sicker patients. There's a lot of cutbacks. There's a lot of people who are calling in sick because they're under stress, and increasingly there's more and more burdens placed on nurses. And in moments of stress, it's hard for them to spend the time taking care of all the needs of frail seniors. And, you know, certainly if you are a family member of somebody who's admitted to hospital, who's a frail senior, you know you're doing a lot of the care. You're walking your loved one around. You're helping to feed them. You're not changing them, you know, unless you want to do that. Nobody's going to make you do that, but, you know, you may be spending, you know, it's almost a full-time job just advocating for your loved one. So does that mean that we practice age discrimination? Yeah, we do. We do. This clinician, David Alter, who's a cardiologist and a researcher at the Institute for Clinical Evaluative Sciences in Sunnybrook, thinks that it's age-appropriate decision-making. And, you know, he actually did a study looking for sex discrimination in cardiac care and found instead age discrimination. He thinks a lot of it's appropriate. And you know what? I agree with him. You know, when my dad had his first ACS and he was 89 years of age, he was considered too high risk for a bunch of reasons for angioplasty. It was technically difficult. He had enough renal failure from his untreated diabetes. He's another one of these guys. And they didn't want to give the dye that would have been necessary to illuminate the vessels, and as a result, you know, and as a consequence, put him into dialysis, put him into renal failure with a need for dialysis. So he didn't have an angioplasty, and I remember the cardiac surgeon doing a 2-minute consult. And you know what? I was secretly glad when they didn't offer him surgery, because honestly, you know, he could, being on full bypass, he could have had enough cognitive decline as a result of the bypass that he would have gone from living at home to living in a long-term care facility like that. So I was kind of glad when they didn't. So I don't think it is. But on the other hand, you know, you get a view from others. You get Janice Lessard, who's a geriatrician at the University of Toronto, and she thinks it's false to assume that older people can't stand surgery. And you know, if you look at studies, the frontiers, the age-related frontiers of surgery are changing all the time. And she makes the point that I think is important. It's the point that I was trying to make with why we need more geriatricians. We need anybody who's got modern expertise in looking after older patients. That it is false to assume that they can't stand surgery. If you know how to treat them, if you know what their special needs are, if you know, for instance, how to avoid drug interactions or drug-disease interactions, or how to manage them, how to alter the dose of medication that you're going to give to seniors to adjust for the fact that they're older. Okay? So those, I think I've talked enough about problems. I've scoured the country. I'm going to present some solutions for you in the remaining time that I have left, and I'm going to talk about a couple of other unique paramedic issues. First one is, certainly for those family physicians, you can make practice more efficient. So that's, you know, call it watering the wine, but there's a number of things that you can do, and I've got 3 images here. Alberta Access Improvement Measurements in the bottom left. That's a SWAT team that uses lean principles, goes into a practice, a clinic, a group practice, whatever, and finds the inefficiencies, talks to everybody, treats everybody as an equal, and finds the bottlenecks and deals with them. So, you know, here's a bottleneck that may surprise you. 1 complaint per visit. You ever see a sign that says that? Or 2 complaints per visit? It's actually not a great move. It may be okay for a walk-in clinic where they're just doing patchwork, but in the context of a family practice, it's probably not. And here's why. You get a 52-year-old guy who comes in with a sore toe and you diagnose gout, and you put them on an anti-inflammatory and send them out. Well, you know, they may have a whole bunch of other untreated, undetected problems, latent or real, that will generate appointments after appointment after appointment later on. So what Alberta Access Improvement Measures will recommend is that you throw the book at that guy who comes in with a sore toe, and you book them for everything. You do the electrocardiogram, you do cholesterol testing, if it's appropriate to arrange for colonoscopy, you do all that, and do it now, because get them while they're there. And so you're practicing a kind of secondary prevention. But the other thing that you're avoiding when you do that is, if you do it all now, you don't have this drip, drip, drip of internally generated follow-up appointments. And suddenly, when you start doing that, holes open up in the schedule, so that when a parent calls in to say that my kid has a sore throat or an earache, can I bring them in today? There's actually room. Okay? So you can, and there's lots of other things you can do. That's called max packing, by the way. That's what they call it, max packing. Putting everything into one visit instead of trying to, and of course you have to arrange enough time. You really need somebody smart who's booking the appointment, who's actually gotten enough of the needs of the patient to be able to say, you're going to need this, 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 and that. Maybe they have decision rules. I don't know, but the way to do it, you can make it more efficient, and it starts at reception. Upper left, do you know what that is? Well, there's a doctor there. You see somebody with a stethoscope around their neck. See a whole bunch of people around them. Do you know what that is? That's a group medical visit. 17 people with the same collection of problems, typically diabetes, heart disease, hypertension, hypercholesterolemia, all being seen at the same time. It's a 90-minute visit. There's a physician, there is a registered nurse who's taking vitals and putting them on a whiteboard, and there is a scribe, so that the physician doesn't have to waste time typing or writing notes. Everybody has to, everybody's in the circle of trust, so they have to get the privacy rules. Nobody's talking about intimate stuff there, and what goes in the room stays in the room. I can't believe what Wanda Jones talked about, last. And if you want to say something private, you can duck out or you can book another appointment. But the benefit here is twofold. First of all, when the physician explains the side effects of Crestor to one patient, he or she does not have to explain it to 16 other people. So that's efficient. The second thing is that, think of the peer, everybody comes in and gets weighed. Everybody comes in and gets their blood sugar taken, their blood pressure taken. Imagine the applause when somebody has finally reached their blood pressure target or their blood sugar target. They're doing real well. So that can be very, very helpful. You also get discussions going up where people are contributing and they're able to provide support. Yeah, I had that side effect, but I can manage it this way. So patients are a surprising repository of information that they can share with each other. Think of it as a kind of an in-person chat room, okay? The early studies of group medical visits are promising. Good care, no decrement in care, and obviously way more efficient. Think about how long it would take that physician to see each of those patients one at a time. That's half a day, if not more. Upper right, team. Teams work better. And I've been in places like Hatchet Lake, Nova Scotia, where a registered nurse came to a family physician and said, hire me under a pilot program by the Nova Scotia government, hire me, and I promise you that my salary will be revenue neutral. It won't come off your bottom line. I'll help you see more patients, and in so doing, that will offset the cost of my salary, and you won't take any paperwork home. And that's what happened. And what that physician was able to do was, not only was she as good as her word, this physician was able to take no paperwork home and had a much more efficient practice and was able to see people faster, but he discovered that he wasn't providing the counseling on prevention, and by farming it out to somebody who had the time and the skill to do it, suddenly he was of far more value to his patients for that reason. And she was able to do a lot of the counseling on weight loss, on reducing cholesterol, on how much exercise to get, and how to start. And by the way, how good are physicians at giving advice like that? We had a show on this past week. Not very good. The next professional might be somebody called a health coach. The problem is that we can tell patients what to do, but we often don't know how to get them to break it down into manageable steps. So that's something that working in a team allows you to do. And the idea, I think we have to facilitate that as much as possible. The idea that I can't afford it is just a no-go. Now we come to the most important thing. I know what you've been waiting for. It's time for a new dawn and a new day when we have new players in the system. Some of them aren't so new, but using them in ways that were never done before. And this is old news to you, but I remember being at the Sudbury Nurse Practitioner Clinic, and I remember hearing Marilyn Butcher and Roberta Heel talk about the day it opened in August of 2008, and when there was a lineup stretching twice around the building. These were the orphan patients, and they'd found a home, and somebody has to look after them. And so successful has been that experiment. You know, of all, you know, right or wrong, whatever you want to say about the legacy of liberal government, one thing they did bring were nurse practitioner-led clinics, and that was the first in North America. And, you know, whether there's 25, that's a drop in the bucket of the total number of people who don't have a family doctor in the province. But you can begin to see as their numbers grow that this gets serious, that this is something that could make a big difference. Here is another group of professionals who I think could be used in much more interesting and exciting ways. And in Nova Scotia, I have seen extended care paramedics doing some amazing things. For example, bringing acute care to 15 nursing homes in the Halifax area. And you know, they had a pilot program, and what they do is they come in a specially equipped truck. They don't scoop patients to the emergency department. They assess them. They talk to the families. They talk to the primary care physician, the staff there. They pore over the notes. They've been taught how to do that. If somebody has dehydration, they can set up an IV drip, and then they can go and see 2 or 3 other patients and then come back you know, to see how they're doing, take the IV out. And in the early phase of the program, right off the bat, of 135 patients who by definition would have to have been transferred to an emergency department to wait and be part of that clog problem, that offload delay problem, 93 of them were saved a trip to the emergency department. It's now being expanded for street health and incarcerated patients, and I want you to hear Daryl Bardua, who is one of the first of the, very experienced paramedic and one of the first of the extended care paramedics. Kind of professional, physician assistants. They're starting to crop up here in the civilian corps. They were battlefield medics. At Concordia Hospital in Winnipeg, orthopedic surgeons were concerned that they weren't doing enough hip and knee replacement surgery, so they went around North America looking for models for how they could be more efficient. And the one they settled on was to train and hire physician assistants. Physician assistants are physician extenders. They work under the direct authority of the physician, and the first wave came from other countries. They were surgeons in other countries, but now they're being trained at the University of Manitoba, University of Toronto, McMaster University, NOSM. I think I'm going to have a program. I don't know if they have it yet, do they? And in 1 year, they were able to double the number of hip and knee replacement operations they did, simply by having a physician assistant who could start the operation and do the closure, close the wound, and leave the orthopedic surgeon with the job of putting in the appliance, testing it, making sure it's okay, and then scrubbing out and moving into the next operating room where another physician assistant has started. To me, it's not a question of why, but why not? And you know, this pattern is emerging. If you talk to people like Josh Tepper, who was an assistant deputy minister, now he's at Sunnybrook Hospital, you know, this is the plan, and I hope this plan continues. But we need to have a plan. And you know, I have a vision. You know, my vision has the patient in the middle and looked after by an array of professionals depending on their need. So one level might be nurses, nurse practitioners, paramedics. Another level might be family physician, called in as a specialist when the patient's needs fall outside the scope of those other practitioners. And then in turn, in the same way that I call in a specialist like a cardiologist is called in. For that to work, here's what I think we need to do. I'm not saying it's going to happen, but if I could wave my magic wand, I would have every man, woman, and child in the province, or at least enough of a representative sample, so that we would know, we have to know our population, we have to know who we are, what's our genetics, what are our needs, what will our medical care or health care needs, what will our prevention needs be now, 5 years, 10 years, 20, 30 years down the road. And once we know that, design and make sure that we have the health human resources to deal with that, with those needs. And so, in other words, we're going to have to plan, and that means figuring out what everybody needs. It means recruiting and training the people we need. We have to change the remuneration model. You know, I believe in accountability. You know, for instance, for the same diabetic wound that is treated and followed by community care access in different parts of Ontario, it can cost anywhere from $1,500 to $6,000 to heal the same wound. Something's wrong with that picture. We need to be able to get accountability. So maybe the model is to provide $2,000 or $1,900 to all of them and say that's all you're going to get. So if it costs you $2,400, you're going to eat that cost. And if it costs you $1,400 and you deliver good care, then you can keep the rest. And maybe that's the way to do it, but we have to put some accountability into what I do. Accountability to me is how many patients I saw, how many services I provided. To an orthopedic surgeon is how many hip replacements they did, but not did they have complications. How did my patients do? How many bounce backs did I have today? How many patients did I see who ended up having to come back tomorrow or the next day with the same problem untreated? Okay? If we put account, and I know it's a tough one, but we need to put it in. None of this will work without a team. That system that I've talked about, where you triage every patient and have the right staff, will only work if everybody works together. Can it happen? Yeah, sure it can happen. In Digby Neck by the Bay of Fundy, not far from Halifax in Nova Scotia, in 1998 the last family physician left Long Island. That's Digby Neck in Nova Scotia. And in 2000, Nova Scotia started its first paramedicine program. And there you have nurse practitioners working with paramedics, and the paramedics aren't simply transporting people to, they're not a bus service or a taxi service transporting people to Halifax. What they're doing is they are doing primary care in the home. They're doing home care assessments. They're doing, blood pressure checks, blood sugar, medication checks. They're picking up medications and bringing them. They're just improving the efficiency there and providing a level of care, working alongside nurse practitioners, and they have completely replaced the physician who was there. In fact, that EHS house that you see there used to be the home of the last GP who lived there. It was converted. Here is the best example of team that I have seen in this country. This is Nelson, British Columbia, home of Vietnam-era draft dodgers and some of the best grow-ops in Canada. Not that I know anything about that. Population 10,000. 350 to 400 births per year. They're having, it's amazing. You walk through the street, there's a lot of pregnant women there, a lot of women pushing babies in buggies. And here's the thing. 1/3 of the babies in that town were delivered by a midwife, 1/3 by a family physician, and only 1/3 by the 2 obstetricians in town. In this province, 80% of all deliveries by obstetrician. What's wrong with that picture? We are way behind other countries in bringing midwives, and this is not just advocacy for midwives. The idea here is that each person is practicing according to their skill, to their scope of practice. So midwives and family physicians, slightly different models, both providing more of the primary care obstetrics, uncomplicated obstetrics. When it becomes complicated, they call in the obstetrician. Now, for that to work, the obstetrician only works by referral. They don't have primary care patients. They only see the tough stuff. As Raz Mullah, who you can see in the bottom right there, who, by the way, learned how to do cesarean sections from a midwife in Africa named Big Boy. Raz Mullah says, I get paid to think. He's paid a salary. He's not paid fee for service. He's paid to think. And he is available to come running if there's a sudden postpartum hemorrhage, or if there's twins. Or if in the case, I got to witness this, it's Eileen Bell, who's the midwife who's with him, and this is not just done for the camera, they like each other. And that's important, they like and respect each other, and they all work together in the hospital. These aren't underground midwives who are practicing in a way that these midwives would think of as dangerous. No, they all work together, and they all like and respect each other, they know their jobs, they know when it's time to hand over, and they know when it's time to step up. Will patients buy in? I look at our rising rates of obesity. I think that there's a lot more that we need to do to address that. I'm struck by the fact that we're not addressing the real determinants of health. The ones that were established by the World Health Organization. Things like clean drinking water, air, breathable air, good education, good social contacts, immunizations, advice on how to eat a proper balanced diet at an early age, and so yeah, I have reasons to be a little bit pessimistic. I don't always have faith in my patients, and on our show on White Coat Black Art. We did a story called Lights and Sirens, where I got to ride along with a paramedic in the front seat, and I expected to find that it was cars that were doing crazy things when that were impeding the progress of ambulances. I was surprised just how often it was pedestrians giving you the finger, as they saunter across the road. I want to say something about paramedics that I don't know if this is a problem here, but it was a problem it's a problem in other parts of Canada. It's certainly a problem in downtown Toronto. It may not be a problem here. If it isn't, just tell me. I have so much respect for you for so many different reasons, but one of the reasons why I have respect for you is that I have an office. It's called the emergency department. I have security I can call like that. I have medications, I have restraints. What do you have? You go into somebody's home. Your office is their home. You have no idea what you're getting into, and there's often little advanced warning, intel of the situation, and I spoke to many paramedics who have said there's very little training on how to deal with the unexpected, which can sometimes turn violent, and I just want to play a couple of minutes of Tom Janitos and Sandra Laughlin talking about that issue. And I just say that for a couple of reasons. In Toronto, we actually have tactical paramedics who wear body armor. And it's actually come to that in some jurisdictions of the country. You may be aware of the Jim Hurst inquest, looking into the whole policy of staging, the idea that you stage rather than going into an area that's uncertain. And my heart goes out to you because it's one of those damned if you do and damned if you don't situations. You will be blamed if you're wrong. And one of the things that I want to close with is to say that I admire what you do. It's no accident that paramedics have among the highest rates of PTSD and burnout amongst health professionals. I'm grateful that there are colleagues, Vince Savoya with the Temaconter Memorial Fund, who are providing assistance to people who have burnout and post-traumatic stress disorder. But just for me to say that, I'm glad I got to do the show because I got to meet you, and I'll be happy to answer your questions, but I wanted to be able to tip my hat to you and just say, a job well done. You don't get heralded for what you do, but I'm going to applaud you right now. Thank you very much.
Wow, that was a lot of information. Hopefully, we can work on what needs to be done. On behalf of the board and on behalf of the EMS Symposium, just a small token of our appreciation. Hopefully you have a wall that you can remember Nipissing and come back and entertain us some more. Thank you very much.
Thank you.